Hey everyone, how's it going? Let me know if you can hear me, if you can see me, all good stuff. Anyone there can hear me and or see me by any chance? Oh, there you go. All right, hello. Perfect, good to see y'all here. Thanks for joining me. It's wonderful Friday. And you guys have anything after me, or are you guys all done for the week? A micro online. All right, not too bad, not too bad. And you get a nice 3-day weekend. That's gonna be lovely. Sure. Yeah, that'll be good. Get 2 weeks in, take a day off, 3 days off, and get right back to it. So that's perfect. Brian. No problem, no problem. Yeah, there's not much of a thing as a 3-day week. It won't feel like it because you'll probably be studying regardless, but trust me, there's a light at the end of the tunnel. You won't see it for a while, but once you get under rotation, things certainly take a nice turn on just one, you're getting like actually work and like getting to do the thing you've been here for, and yeah, you have a lot more free time on your hands. You won't believe it. The big catch-up weekend. I'm hoping I'll have enough time to get through everything such that we can have a review on the next time we meet. So I'm gonna see how that plays out. I might have to. We'll see how it goes. Play by ear a little bit. Get it? We're talking about the ears. I used to think that when you like went to med school, you just got to like pick 3 random body parts that you were like really interested in. When I heard about ear, nose, and throat doctor, so I was just like, oh, I guess it could be like a finger, belly button, and foot doctor, but that was not the case as it turns out. Incorrect in my assumptions. Boy, yeah, I wish colleges paid you to go, but that is not the case. At least here in the old United States. Let's see here. All right, I'm gonna go ahead and start recording. I am praying my internet is gonna stay stable, but I had some issues this morning, so I'm hoping that the internet goblins will take pity on me since I already had to complete shutdown earlier. But regardless, if things go down completely, I'll just keep going, and then I can post a video up later so you guys can catch up. So that being said, let us continue on. So anyway, so looking at this, we were talking about our ENT medications before. We left off on the antihistamines, and I just briefly wanted to make sure we touch back on that to make sure we had a good understanding of kind of what these drugs are doing. And remember, with the first gen drugs, they are able to cross that blood-brain barrier. They have decent enough lipophilicity that they can cross over no problem. So you really want to know the side effects associated with that, some of which we can use to our benefits and some of which are going to be detrimental, right, depending on sort of the situation. So for instance, I would ask you like a test question, and I said, oh, you have like a truck driver who's driving like 12-hour days and he's having all these allergic symptoms and he's got runny nose and watery eyes. Which one of these would be most appropriate? And, I could put like 3 first generation drugs, and you have to be able to figure out that, okay, well, why are these 3 first-generation drugs is not a good option. And you could say, okay, well, they're pretty sedating, so that's probably not great for someone who's got to be with it enough to be able to drive. Although I will tell you, as just having driven to Atlanta and back, many of those truck drivers seem like they're on some sort of mind-altering substance as it is. Regardless, though, remember other things like the anticholinergic effects can be pretty strong with these. Think about things like the mnemonic that we used last time, at the end of last semester, to remember what our anticholinergic effects are, right? Remember, you can be mad as a hatter, meaning you can have some altered mental status. It can be sedation. It can be excitation, depending on what kind of reaction they're having. You can see dry as a bone, meaning they're going to have a lot of decreased secretions. They can have urinary retention, things like that. They can be red as a beet, meaning they can have some cutaneous vasodilation, so you get kind of flushed in those cases there. Not that everyone has these symptoms, but these are things you can see if someone took a bigger dose than normal or may be predisposed to it. There is hot as a match or hot as a hare. Not that I know hares to be all that hot, maybe hot as Hades. Meaning they can get hyperthermic. And then the last one would be blind as a bat. So you can see, and we'll talk about this with the eyes a little bit later on, that you can have some, you'll have mydriasis that occurs there, and then also you can have some impaired accommodation, such that it can be difficult to see, right, which can lead to some additional issues if you had someone needing to operate heavy machinery, for instance, right? So the second generation drugs, though, kind of don't have to worry about that as much, mainly due to the fact that they have that positive permanent charge on it. They can't really cross the blood-brain barrier so well, and so that's why you end up seeing a lot less sedation there with those, okay? The side effect profile very different between them. Now, if you had someone who was having like a lot of secretions or something, and you wanted to dry them out, so to speak, then something like a second generation agent would be a bad option there for those, right? So got to kind of think about, what this clinical situation is and what kind of profile you're looking for in terms of your medications. Now, one last one we'll mention here is called a zealostine, which is a nasal spray. This one you don't see used quite so often. Some of the benefits of using a locally acting medication is the fact that it only works kind of where you put it. So in this case here, it's good for like nasal symptoms. Doesn't really work for the eyes, doesn't really work anywhere else. And so in those cases there, if those are the only symptoms your patient was having, that could work, but you will find that it doesn't really work for much else. In terms of side effect profile, not that much. You can see some epistaxis maybe due to drying out of those mucous membranes, can lead to some drying and cracking there, which could lead to some bleeding, and then a bitter taste. And that's probably more common, mainly just due to some of that postnasal drip that can occur and hit the back of the tongue there. So that's another thing you'll see normally. Now, this is kind of general information for patients when they are administering nasal medications here. Typically, you want to clear out the nostrils first, make sure there's no kind of gunk in there that could kind of impede, the mucous membrane contact with the medication there. Have them tilt their head down, angle the spray sort of away from the septum. You don't want them to accidentally cause any kind of septal injury there. Point away, and they'll kind of use left hand for the right nostril and vice versa there. And then by preventing them having their head tilted forward, it kind of prevents some of the medication from going into the back of the throat, which can be kind of unpleasant for some patients there. Another thing too, make sure you clean off the bottle tip. Make sure they know not to share with other patients, because you can kind of spread disease that way. So definitely watch out for that. Typically, if they have nosebleed that starts up, they should be pretty self-limited, but you may want to consider telling them, maybe this drug is not a good option for you, and maybe something more systemic would be better, right? So again, that one's not used quite so commonly, but it's good at least to mention it. Next off, we have some ENT corticosteroids. Oh, actually, I don't know if any of you heard about this, but The Rock and his whole family, Dwayne Johnson and his whole family actually just caught COVID, which I thought was kind of interesting. I know I bring up COVID quite often, but that is the landscape that we're living in now. And they said that the first signs they were really worried about COVID is because they couldn't smell what The Rock was cooking. So there you go. Anyway, let's get into some of the steroids here. So what are steroids actually going to do for us? Well, they help really limit the amount of inflammation that's going to be happening here, and that's going to happen with a lot of different cells, and they're going to help to limit a lot of the inflammatory cytokines that you're producing and things like that, to overall lead to things like decreased mucous membrane secretion. You can see smooth muscle relaxation. All these things here are going to be happening as a result of where your steroids are working. Now, one of the things to note with steroids, though, is they don't work super fast. And the reason for that is because while very powerful, they work very slowly due to the fact that they work actually on the DNA itself. The glucocorticoids, which is another name for a steroid, or corticosteroid, I should say. When we talk about steroids more broadly, we'll talk about the adrenal or mineralocorticoids, and we'll talk about the glucocorticoids. And there's some delineation there in terms of their action. But mainly when I'm talking about anti-inflammatories and I'm talking about corticosteroids, I'm talking about glucocorticoids specifically, because that's going to also talk a lot about some of the side effects we'll see there. But anyway, so looking at this, we can see that once it gets into the actual cell itself, it will go down into the side of the nucleus and can alter gene transcription, right? It can start to promote or inhibit certain areas of the DNA from being expressed and having those proteins actually forming there. And so by doing that, you can see that it does take a while because it actually has to modify the proteins that the body is producing. And so while very powerful anti-inflammatories, it takes time to kick in. So in cases of ENT concerns, if possible, we like to avoid giving systemic corticosteroids. We're going to see there's some issues with those, which I'll talk about here in just a little bit. Usually systemic steroids work a little bit faster, but if we are only dealing with seasonal rhinitis and things like that, nasal corticosteroids tend to be the way to go because they help to limit a lot of that systemic effects there. Note here that many of these are also going to have varieties that are given via inhalation for asthma. So you can see they can kind of do the same thing whether used in the nose or in the lungs. Similar actions there that can be helpful. But you can see here some of the common ones. The problem though is that a lot of times people will get the brand names mixed up. Some of them are a little bit more clear in terms of their brand name. So for instance, like budesonide is called Rhinocort when used in the nose, which makes sense, rhino nose, versus when you're using it for respiratory purposes, it's called Pulmicort. So pulm, lungs, that makes sense. But things like Flonase and Flovent, a little bit easier for people to get mixed up. And so that can be something your patients might mix up when they're telling you. Sometimes they're on both. So there can be some issues there. So make sure you know what you're talking about. We have beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and then triamcinolone. These are some of the more common nasal corticosteroids you're going to use there. And we'll talk about the asthma ones when we get to pulm a little bit later on. Note here that typically when you're using corticosteroids as anti-inflammatories, they can have a negative effect on wound healing. That's more specifically when you're taking them systemically, but what you can notice here, that the same thing can happen locally. So for instance, you can have some nasal septum perforation as a rare side effect, but can happen, and it kind of makes sense if you're using that steroid to kind of chronically suppress wound healing. Even micro injuries can kind of build up over time. Other things include epistaxis and unpleasant taste there, but beyond that, they're pretty well tolerated. The issue, though, is that you need to make sure they're taking them consistently, right? And it can take a couple of weeks before you really see the true effects sort of kick in, which is why sometimes you'll start patients, say it's the first time you're seeing them, they're complaining of allergic rhinitis. You can give them something like, antihistamine to sort of cover them for that period of time until the nasal steroids sort of kick in, right? Because it will take a few weeks. And patients have to keep taking it because they may realize that, okay, well, my symptoms are getting better. It's been, 2-3 weeks. And then they stop taking it, and then the symptoms will come right back, right? Which that may be okay if they're doing it for a seasonal purpose, or if they're doing it as a result of a certain allergen that triggers them, animals or something like that. But for someone who's having maybe year-round issues, this is where they need to make sure they're taking consistently. Otherwise, the effects will go away. Now, what if I wanted to use something systemic that's going to get me sort of better actions here? You would use these rarely, but you might use them in combination with someone who's having maybe severe sinusitis, and you may think it's bacterial. Maybe we'll also give them some dextromethorphan to help out with some of that inflammation. We use these a lot for asthma exacerbations and whatnot, and they're all kind of still the same purpose here. Amber was asking, how many doses can you miss to still have the effect? That's probably going to be on a case-by-case basis. Obviously, the more you miss, the more your chances are some of the effects starting to come back. But if they miss 3 or 4 doses worth, I wouldn't tell them to just use all those sprays at the same time, because again, the nose can only handle so much contact with that drug before they just start stripping out their nose. So I wouldn't tell them necessarily double up on doses. Just get them back on track and have them just keep taking it like they should be. But anyway, so switching over, if we're talking about systemic corticosteroids, which you may use occasionally, this is typically done in terms of ENT cases, for short course. So this is a couple of days worth, maybe 5 days worth, probably no more than that. Cassette, maybe you should use your Flonase more regularly. who could say, right? I don't know what your nasal symptoms are like, but keep in mind, I give no medical advice here. So, this is all just for our hypothetical patients we might be dealing with. I don't get like sued over something by telling someone to take more of their medication, and that might not be right for them. But anywho, I oftentimes have students who like ask questions. They're very specific to someone in their life, and I have to be like, well, I don't know about them, but if I had a typical patient like that, or a patient that was similar to that, here's what I might think about. You got to keep it pretty hypothetical. Anywho, getting back into dexamethasone, usually short course needs, if you're having someone with like a hypersensitivity reaction, allergic rhinitis, asthma, typically pretty short courses here, which will limit some of these side effects you can see with these. But things you'll see also depend on the patient you're dealing with. So if they are predisposed to some of these side effects, this is obviously going to increase their risk. So for instance, corticosteroids being glucocorticoids, specifically gluco, you think sugar, you can find glucose intolerance. It actually helps to stimulate gluconeogenesis in the liver, which will raise blood sugar levels, which might not be great in someone who's a diabetic patient, right? Or you can also see fluid retention in the kidneys because it can actually have some effects that are similar to things like aldosterone, which is our primary mineralic corticoid. But you'll see there is some crossover effect here with our corticosteroids. They can both act as mainly a glucocorticoid, but also a little bit like a mineralic corticoid as well, which we'll talk more about that in detail later on. Other things can include, hirsutism, Cushing's-like symptoms there. Tendon rupture is a pretty rare one, but that goes back to that impaired wound healing you can see with that. Important for our purposes here in just a little bit when we get to ophthalmology is talking about like increased intraocular pressure leading to worsened glaucoma. For most typical patients who don't have glaucoma, this is not going to be an issue, but they have those pre-existing conditions that would be worse in there, right? And so in these cases here, it may just be that, you can work around the issue. So for instance, if someone is a diabetic patient and they are insulin dependent, for instance, and they had to go on dexamethasone, well, they can modify their insulin dosages, right? That could be something they could do. Or you may decide maybe not to use the medication at all, or perhaps lower doses. So there are ways you can kind of modify things in order to try to get around that, and you'll get a better feel for that when you're actually out there in clinical practice. Note here too that giving anti-inflammatories tends to suppress the immune system, so specifically corticosteroids, and that can increase your risk for infection. Now, is it going to happen over a 5-day course? Not really, but you can see for patients who are more on this for like long-term, larger doses, you're going to find that is a risk. Either secondary bacterial, viral, fungal infections, all are going to be increased in risk due to this weakened immune system you can see with that, right? So all of it has to do with the context, how long they're using it, how big of a dose. One other thing you're going to see too is that you have to be careful because when giving dexamethasone, it's replacing the cortisol that your adrenal glands are normally producing. And so it activates that negative feedback loop and will tell your adrenal glands stop producing any more cortisol. And so you can find for patients, especially if they're taking it for more than a week, that they have to wean off of their steroids, right? Because you have to give the time for the adrenal glands to sort of kick back on. If you were to have someone taking, say, high-dose dexamethasone for 3 weeks, and then you cut them off cold turkey, they would go into adrenal insufficiency because their adrenal glands just need time to kick back on because, again, it's having to upregulate that from the DNA level even to produce those new molecules of cortisol. So if they're on it for less than a week, though, typically not a concern. You can write for a 5-day prescription for dexamethasone and not worry about tapering. Although you will see in a lot of like methylprednisolone dose packs or something like that, they build a taper into it. It's not strictly necessary, right? But anyway, so corticosteroids can cause a host of different medication interactions, as we'll see here. So for instance, if someone's taking a diabetic medication, yeah, that's going to decrease the effect because it's raising blood sugar, right? So there's sort of a physiologic antagonism that happens with these. You may run into issues where like diuretics plus something like dexamethasone can increase risk for hypokalemia due to its effects working kind of like an aldosterone-like product there in the kidneys. We'll talk more about that when we get into specific diuretics, but these are some common things you might run into occasionally, right? So in terms of contraindications, you want to be careful if they have a existing fungal infection due to the chances you can actually end up causing decreased ability for that patient to actually fight off that infection. So that's one thing to note there. I apologize, my internet connection kind of comes in and out a little bit, but it's kind of the nature of the beast, unfortunately. As I mentioned, don't abruptly discontinue dextromethorphan and Theranos for more than a week, and there is that risk for decreasing the immune system, so just be aware of that. Now, when you get into some of the other corticosteroids you may run into with some regularity, there's dextromethorphan, which is a good one. Prednisone and prednisolone are another two that you're going to see pretty commonly. Prednisone being the oral tablet formation there, prednisolone being the liquid formulation. Prednisone actually gets converted into prednisolone in the liver there, but the prednisolone is a liquid variety that we typically give to pediatric patients, right? So that's a pretty common one there. And so, again, same activity here. The only real difference you're going to see between things like dexamethasone and things like prednisone or prednisolone is the relative potency between one another, right? Typically, you'll find that dexamethasone is much more potent than something like prednisone. So as an example, and also the half-life's a lot longer for dexamethasone. So if I had someone with like an asthma exacerbation, I might give them 5 days worth of prednisone. I might do like 60 milligrams daily of prednisone for 5 days. Whereas with something like dexamethasone, it's kind of nice because there's a long half-life. I can go ahead and give them 2 doses, like 36 hours apart of, maybe something like 10 milligrams instead of 60, and that will cover them for that same 5-day period, which is pretty nice. So it depends on, not to say one's better than the other, it's just the dosing strategies will be a little different based off of those kinetic sort of differences between the drugs themselves, right? You're like, well, why do I dose this corticosteroid this way and this one this way? A lot of it has to do with their relative potencies in terms of how they're going to have their corticosteroid effects there. Okay. Another thing too, you want to be cautious whenever giving patients who are receiving, especially large doses for long-term steroids, because you're suppressing that immune system. You want to avoid live vaccines. We'll have a whole vaccine section next semester, which hopefully I'll be able to add the coronavirus vaccine too. But you're going to see here, if you are giving people with a compromised immune system a live vaccine, there is a possibility, because usually live vaccines are attenuated versions of the virus or the bacteria. They're kind of weakened. For those with a compromised immune system, they can actually cause real infection. They can actually take hold and cause disease in those patients. So that would be something to be cautious with. That's more for someone taking it like for rheumatoid arthritis, high doses, long term. This is not going to be for your typical 5-day course of prednisone for, rhinosinusitis or something like that, right? All right, next up, and again, these are not the only corticosteroids you're going to run into. These are just some of the common ones you'll see in ENT, just to get you guys familiar with them. Next up, we have our ENT decongestants. So what are our decongestants going to do for us? Well, remember when you're having an allergic response, you're going to see that vasodilation that happens. You have the increase in mucus secretions. You're going to have those leaky capillaries that's causing that edema to occur. This is where we can try to reverse that by trying to constrict back down on those blood vessels, right? And so here's an example of one called oxymetazoline, or Afrin is the brand name. There's a few other ones that we'll see, especially in the ophthalmology section coming up in a little bit. And again, how does this work as a decongestant? Well, this is actually an alpha agonist. If you refer back to our talk of the sympathetic nervous system, you'll recall that alpha-1 receptors are responsible for causing vasoconstriction. So if I had these vessels that are nice and widely dilated because of the allergic response due to histamine and things like that, by giving an alpha agonist, I can constrict back down on them and decrease that congestion, decrease edema, decrease fluid output, all of that from that standpoint. And again, this is a nasal spray, so it's only going to be working locally in the nasal tissues. It's not going to be necessarily affecting the patient elsewhere. Now, because it acts as an alpha agonist, typically you're going to see just local action here, but you can see some patients, especially those with pre-existing hypertension, that can be worsened a little bit. There is still some bioavailability. We can't say it's not going to affect the hypertension at all, but if they were, severely uncontrolled, I may decide against something like this, right? So that's something to note there. Now, what happens if I'm chronic, say you have someone who's been sick for a week and they've been taking Afrin that whole time round the clock? What can happen? Well, remember that if I'm chronically agonizing those alpha-1 receptors in the nasal mucosa, what happens to the receptors? Do they upregulate, downregulate? Well, as I'm constantly activating them, they're saying there's too much activation here. Let me go ahead and try to downregulate some. So they'll actually decrease the number of receptors available at the blood vessel site, right? So what happens if I decrease or discontinue Afrin immediately? Just abrupt discontinuation. Well, now all of a sudden you have fewer alpha receptors on those vessels to respond to what normally activates them, like epinephrine and norepi. And so what happens is you end up having less activation of those receptors, and the vessels have a rebound vasodilation, which maybe is worse in terms of causing rhinitis than what was ailing the patient beforehand. So we call that rebound rhinitis or rhinitis medicamentosa, right? Caused by a medication. And so this happens even after 3 to 5 days. If I've been taking it longer, rebound rhinitis is going to be quite severe. And so what do you do if you get this rebound rhinitis? Well, the patient's going to go right back on the Afrin, right? So you come into this situation where patients become physically dependent on the medication. And I've seen some people who, there's one pharmacist I saw that basically they had a big long counter like at a CVS or Walgreens. He had 3 bottles of Afrin spaced throughout, and he would just go through his day, and as he felt his nose was starting to plug up again, just take a spritz and then keep going, So, not an addiction in the strictest sense, but a physical dependence can certainly occur there. Let's see, exactly. So Afrin can be your best friend and then your worst enemy. So how do you overcome that? Well, you can gradually titrate down on the dose and hopefully use fewer and fewer dosings throughout the day. And eventually, over the course of maybe a few weeks, you can try to get them off of it. But again, that's an important thing to educate on because of the fact that they don't know about it. They just think that, okay, well, their allergies are coming back, not realizing it's related to the drug itself. So, as I mentioned, don't use it for more than 3 to 5 days. In a lot of places, like for instance, with our system over at Nemours, we hard cap it to no more than 5 days. It'll automatically discontinue the medication off of their profile in order to prevent this from happening here. Again, the directions are going to be the same as any of the nasal meds we've already talked about, the nasal corticosteroids here, so no difference in terms of that. But the education point about the duration is super important, right? Now, something I could use, maybe the patient is not a good candidate for intranasal use. Let's try something like pseudoephedrine or Sudafed. Most people have probably heard of Sudafed before. Most people are probably familiar that you're unable to get Sudafed from over the counter, strictly speaking. Now it's more of a behind the counter sort of drug there. And the reason for that is because people were trying to make methamphetamine out of it. What's actually kind of interesting is that Sudafed, if you take this and then do a urine drug screen, there's a chance that it will cross-react and actually show that you were taking methamphetamines, even though you were just taking Sudafed, which is kind of interesting. So because they were worried about people making meth in their homes, they went ahead and decided to make it behind the counter, and then they added this whole registration system where you can only get so much filled out during a month and all this kind of stuff. So seems like a whole lot to do for probably something that wasn't happening quite as often as you might think, but yeah, definitely would not take this before sleep. Yeah, a lot of budget Walter Whites, I suppose, which I don't know that I would ever want to take anything from someone who had homemade their own medications there. But I come from a very small part of Florida. If anyone's ever heard of Interlaken, Florida, that's a very small town, and I lived down a dirt road all of my life, and we certainly had a few trailers that went up in flames, maybe or maybe not due to clandestine meth labs, but it is what it is, So yeah, so see, Kaylee said we had to do a lot of quantitative analysis on drug screens in the pain clinic I worked on for that reason. Yeah, so typically, don't worry yourself about taking Sudafed and then popping positive on a urine drug screen. Typically, we have to do confirmatory testing, like a GC mass spec or something, in order to get clarification on that sort of thing. But yeah, even with poppy seeds, you'd have to eat a whole lot of poppy seeds to show for opioids. But I don't think it's one bagel is necessarily going to pop positive. A lot of it has to do with the sensitivity of the test and what their limits are in terms of showing positive or negative. And it was funny when I was in school, I had a professor, went to UF for pharmacy school. And of course, there's that rivalry with FSU. And one of the teachers there, I don't really have a strong stake in football teams by any means. But I had a professor who was very funny in talking about, I was like, yeah, well, the FSU team, football team, never pops positive, but they also set their limits so high that you'd have to be actively doing cocaine before you took the test to actually show positive. I don't know if that's true or not, but I always thought that was kind of a funny thing to consider there. So anyway, looking at this, so Sudafed is going to be more of a systemic drug, right? A systemic decongestion. So instead of just taking it in the nasal, cavity like you would see with an Afrin, this would be something where you would end up taking it systemically, take it orally, right? And it does the same thing, but in this case here, this is even worse for patients with hypertension because it works all over. So you can see definite rises in blood pressure, but it's definitely going to work in the nose as well. So this could be good for those type of patients there. Now this can also help out with things like eustachian tube dysfunction as well, due to that some swelling you can get in there too. And so sometimes that can be useful. It's something obviously Afrin would not be able to treat at all, but this can help out there. But again, think about what's going to happen as a result of this. You know, you're increasing blood pressure. You know, that can do things like lead to headache. You can see some tachycardia that happens here. It has to do with some of the reflex mechanisms. When you increase the blood pressure, you know, your heart's going to try to beat against that, which may cause some tachycardia. So just be aware of that. Those are going to be the main effects here. So Sudafed, Afrin working similarly, just working, Sudafed working systemically. Now, note here also, if they're taking antihypertensives, that this is going to decrease the effects of those drugs, right? Because it's going to be directly raising it, while those other drugs are trying to lower it there. Brian was saying, remember a Mythbusters episode about the poppy seed thing? They ate like 2 cakes each just to test positive. Yeah, exactly. So it has to do with the sensitivity of the test there. I'm sure there's some that are more or less sensitive, just how it is. Now, one thing I want you to know, and this is a good patient education point, and some of you might not even know this, if you see Sudafed over the counter, just to where you can pick it up from the store shelf, that is typically going to be it will have a PE on the end of it there, and that stands for phenylephrine. Phenylephrine, when taken orally, is like super wimpy. Like, if a patient's got severe enough rhinitis where we're taking a decongestion for it, tell them just to go to ask whoever, either the pharmacist or in the front counter, or wherever they have it, get the real stuff. Get the real Sudafed that has pseudoephedrine in it, because taking oral phenylephrine is not great. IV phenylephrine can be a very good drug, as we use it in surgery all the time to help maintain blood pressure. You can use it to treat priapism, lots of different uses for it. Parenterally, orally, not a great drug. So just a good patient education point there for them. Up next, we have our antitussives and expectorants. Obviously, antitussive is going to prevent cough. Expectorant is going to try to get them to expectorate mucus and things like that might be building up. So why do we cough? Well, typically it has to do with some of these cough receptors we have in the respiratory tract. And it can respond to a lot of things like chemical irritants, mechanical irritants like dust and things like that. And basically there's a pretty intensive reflex mechanism that happens here between the brain and the respiratory tract there that causes this deep inspiration, this glottal closure, contraction of the chest wall, diaphragm, everything contracts up. And what's interesting, you can get these really high pressures and speeds in the air coming out here, which, as you might imagine, if someone was infected with coronavirus, can send that all over the place, right? So wear your mask when you're out there, please. Anyway, cough in and of itself is not necessarily all that, dangerous, but you can lead to things like insomnia if they're coughing all night, musculoskeletal pain. I mean, even in rare cases, you can see things like rib fracture, dysrhythmia. I wouldn't expect to see that most of the time, but this is why we wanted to help manage this, and try to prevent those complications and try to kind of get the number and severity of coughing episodes sort of under control. And again, it just doesn't bother the patient, but anyone around them, right? So if they have a loved one or someone who's around them all the time, they may kind of go crazy listening to their coughing all the time. So a couple ways we can do this. First off is going to be benzona tate or Tessalon. These are called Tessalon pearls here. Now, this is something you might never deal with because you guys are going to be PAs and not pharmacists. But these go down. I absolutely hate these things because anytime where I've had to work in a retail setting, whether in school or some limited time, when I was working professionally, trying to put these out in the little pill tray in order to count these out for a patient, they go everywhere. They're like, I don't know what they're coated in to go everywhere, but they always end up on the floor for me, and I end up having to throw a whole bunch away. So I hate these things, but they can be decent in terms of being an antitussive. What do? Well, they actually end up anesthetizing some of those stretch receptors in the lungs that work to help trigger that cough reflex that I was talking about before. So it can be useful for helping out with symptomatic cough and those non-productive type of patients there too. Progesterone too. I don't remember having too many issues with that, but I guess maybe I didn't have a whole lot of that going on at the time. My retail experience is very limited. Again, I probably don't have time to tell the story, but I will tell you that the reason why I don't work retail pharmacy, my second day when I was working, I was as an intern between like my first and second years of school. I was working at a CVS in Jacksonville. It was not, to say, the nicest part of town. And my second day working there, we actually had a guy come in with a knife looking for some hydrocodone. So he ended up stealing a whole bunch. And I said, I don't know if I want to be working in this realm anymore. So after that, I decided to go to the hospital, and I said, if I get robbed at the hospital, then I'll know pharmacy's probably not for me. And fortunately, I never got robbed there. So there you go. But anyway, so looking at this, yeah, everyone was fine. No one got hurt or anything. The guy actually got caught, and they brought him back so we could identify him and all that fun stuff. You know something's weird if it's like in the dead of summer in Florida and a guy walks in with a ski cap and a sweater on. Things are not right, for sure. Anyway, so looking at this, in terms of contraindications and patient information, one really important thing on this is you want to make sure not to crush or chew or cut open this medication here, right? So this is going to be one of those things where there's what they call a do not crush list. Typically, those are going to be medications that are like extended release products or something like that, where if you crush them, you break that extended release characteristic, and all of them gets released all at the same time. Jacksonville gets called out in a lot of movies. Actually, Jacksonville gets called out in The Good Place, which is a pretty interesting one there. I don't know why I keep talking about that show, but anywho, the reason why you don't want to cut into these is because these are anesthetizing, just like they do on the stretch receptors that are in the lungs. This will do the same thing actually on your tongue. So if you had a kid that got into this and was chewing it up, they would actually complain of a numb tongue, and we don't want that to happen there. So anyway, moving on. Yes, it is. It's a pretty big, messy kind of city. I kind of like it still, but it's kind of a mess. It's kind of like southern Georgia, but it is what it is. So anyway, moving on. Next we have dextromethorphan, otherwise known as like Robitussin or Delsum. Those are common brand names you'll see there. Now, I don't know if anyone knows why I put a picture of Bender the robot here, but that has to go with some of the abuse of the medication that you can see. Yeah, I like Jack's too. Jack's Beach is great. Riverside's great, you know, but there can be some other parts of town that are not as great, but that goes for any city, I guess. But anyway, looking at this, you can see here as an antitussive effect. It works basically, and it was interesting here is that it's related to codeine, right? Codeine is going to be an opioid analgesic, and one thing we'll learn about opioids is they are also antitussive. But, you know, I don't want to necessarily give a medication to a patient that have them stop coughing that can cause euphoria and can be psychologically and physically addictive. I don't want to do that necessarily. So instead they have dextromethorphan, which is chemically related, but doesn't activate those same sort of opioid receptors there. And so it's thought to suppress that cough center in the medulla through some of the sigma receptor activation. There's some other things that it does too, like block NMDA receptors, which is a glutamate receptor, which can lead to some of the side effects that we're going to see there. So we give it for cough. You know, it's available over the counter, very easy to get a hold of. And you'll typically find that when adolescents come in for like drug exposures, typically it's going to be related to like stuff you can find around the home. So either like prescription meds that their parents had or grandparents had, or it's a lot of OTC stuff, because you can find patients will abuse this when they don't have a lot of monetary resources to get a hold of harder drugs or things like that. So these are readily available. No one's going to bat an eye at someone buying, you know, a couple bottles of Robitussin and they just think they probably have a cough or something. But so good for cough, but some other things you can see, especially with increasing doses, you can see things like confusion, excitement, agitation. There's risk for things like seizures that can happen with really high doses, and it causes a sort of like hallucinations and sort of a euphoric effect as you get higher and higher doses there. Other issues you run into include things like serotonin syndrome. Remember I mentioned that back with Zyvox, and we'll talk about this again when we get into the behavioral health section with like our SSRIs and drugs like that. But just know there could be a risk if you had someone who was, say, taking depression medications and then took Delsum. Maybe this is something they would not want to mix together because it could have a risk for serotonergic toxicity there. So be cautious, especially anything, you know, taking an MAOI, which is a specific type of kind of old school antidepressant drug. We'll learn a lot more about that later. So just know that there is risk for pro-serotonergic drugs to interact with dextromethorphan and cause serotonin syndrome. I would just leave it at that for these for this part here. Now the reason why I put Bender on here is because so I think Lil Wayne sees from Robitussin. He might have. I don't keep up on Lil Wayne all that too often. But you know, if you ever hear of like scissor or purple drink, that's actually codeine mixed with promethazine, which we mentioned promethazine being an antihistamine, which in high doses can cause some CNS effects there. Plus codeine causing its CNS depression effects. So there's abuse of that, but that's a prescription product. Robitussin though you can get from anywhere basically, but. So I put this here because when they call, say when patients have increasing doses here, that's where you end up getting what they call robotripping. If you hear someone robotripping, that is referring specifically to Robitussin or taking really high doses of dextromethorphan. You get some really kind of wild dissociative sort of effects when you get up to like really high doses. I don't recommend it though, because it's a pretty harsh high from what all accounts, and the seizures can be quite difficult to manage. So, at a baseline, just don't do drugs unless someone's been prescribing it to you. The last thing here I think we'll talk about, or one of the last things, is going to be guavenosin. This is going to be a pretty, pretty mild drug. Most patients tolerate this just fine. It works as a mucolytic and an expectorant. So what it's going to do is help to kind of decrease viscosity and loosen up some of that mucus, so that way they can actually expectorate it a little bit more easily. Not a ton of side effects, so to speak of, but the one thing I would have patients do is make sure to drink plenty of water with this, right? They can have, really thick, tenacious sort of mucus down there, and if they can't hydrate it with anything, the guavenosin's not really going to be able to do a whole much with it. So make sure they're drinking plenty of fluid. Have them make sure they can let them know they're going to expect an increase in drainage, right? Because they're breaking all that up. And of course, with any of these things, if symptoms are not improving or if they're getting worse, have them follow up, especially 5 days a week or something, because there could be something else going on. It could be a bacterial issue, things like that. So anyway, that's it for this section. If you guys have any questions, feel free to post them up. Let me see here. I don't have any questions here on sticky board yet, so let me open up. Yeah, so when would you use an expectorant versus an antitussle? That's a good question. I always thought like the two were sort of contradictory a little bit, because you think, okay, one keeps you from coughing, but the other one makes you want to kind of cough up the stuff. And it's not uncommon that you'll see guavenosin DM or like Mucinex DM, and that's actually containing guavenosin plus dextromethorphan, right? So clinically, I don't know how much sense it really makes to combine the two together, but I guess you can say, well, at least it will break up the mucus that they're having in there. If they feel really congested in the lungs and they know they got something to cough up, but they're having a hard time with it, that's where the expectorant can really help out with that. Whereas on the other hand, they're having just that kind of nagging chronic cough, then I would say more go with the antitussive side of things there. Right. And remember, you got to ask too, because there's some drugs that can actually cause cough. So you want to make sure that they're not taking any of those drugs too that could be interacting. We'll learn more about those a little bit later on. So I don't know if Gaston uses guavenosin. I'm missing that reference there, but maybe I can get some chuckles out of it. Anyway, so let's talk about ocular pharmacology here a little bit. Again, the medications we're going to be talking about for this are going to be locally applied. When I say topical in terms of this, I'm talking about directly onto the eye itself, or maybe into the conjunctiva. So that's mainly what we're going to be talking about in terms of giving these medications at. And of course, you've covered the eye anatomy already. You've already had an ophtho exam, so I'm not going to rehash a lot of these anatomy sort of issues here. However, one thing I want you to note is that there's different sites where you can actually give these medications at. Now, for you working as PAs, you're probably going to be mainly sticking with the topical side of things. However, you may be dealing with like ophthalmologists and things like that who will do more invasive sort of injections around the eye, in and around the eye. So things like subconjunctival routes, the retrobulbar route, things like that. Maybe either for infection or for surgical purposes, they can go via these different routes here. But mainly, we're going to focus on topical administration here. So, there are always going to be some issues with any of these. Obviously, if you're giving it topically, it's convenient, it's economical, it's pretty safe for the most part. Maybe there's some risk with infection if the bottle gets contaminated. We'll talk about sterility a little bit later on. Compliance is an issue because patients don't like to administer eye drops to themselves just due to it being, a little bit more complicated, and they kind of, typically people are pretty protective of their eyes there. These other routes that you can have are going to be more done like in the surgical sort of standpoint. Note here that in terms of systemic absorption, these ones down here are going to be a little bit more likely to occur because you're actually directly injecting with medications there. Topical, though, we can still see some bioavailability, and I'll talk about which drugs specifically I want you to worry about in terms of causing systemic effects when using these versus some that are mainly just going to be working locally. Yeah, fortunately, I don't have to use too many eye drops, but I imagine it's not too fun to do frequently. Most of the drugs we have here are going to be given as solutions. Suspensions occasionally for drugs that have like limited solubility. Sometimes we'll give medications as ointments or gels. Keep in mind these are specifically formulated in terms of tonicity and pH and all of that stuff to make sure that it's compatible with the eye. That's why I mentioned before we don't use otic medications in the eye because it's just not formulated there and it will irritate it quite severely. versus I can use eye stuff anywhere else and it's not really that big of a problem, right? Some cases we can use things like solid inserts. We're going to see that anything that prolongs contact with the eye is going to stick around for longer and it's going to have more absorption of the drug, which can help from a sort of therapeutic efficacy sort of standpoint there. You know, suspensions and solutions, they're just going to be, they're going to go along as soon as you're producing more tears, they're just going to flush it away relatively quickly versus if I have something like an erythromycin ointment, it can stick around there for a little bit longer. So there could be some additional utility of using something like that. There'll be some downsides though for those, as we'll see in just a little bit. In terms of other ways we can do this, you can even have like implants that can be provided here. This is an example of a ganciclovir, which we talked about before as being an antiviral product for someone who has cytomegalovirus retinitis. You can actually give this and kind of locally release the drug right into the eye to have very local effects, very high concentrations right there to treat that CMV, right? So in terms of the kinetics that are a little bit different with the eyes and we'll see elsewhere, is that how well things get absorbed or the extent and the rate of those. We're going to see here that the longer they're spending time in the cul-de-sac and the precorneal tear film, the longer they're going to be sticking around for. Most drugs will end up running out through the nasolacrimal drainage, and that's actually where you can see some of that systemic absorption occur because it's pretty vascular. You're going to see it can absorb things systemically in those cases there. Some things will stick around for longer if they're binding to tissue proteins, and some will even be able to cross the cornea and the conjunctiva based on lipophilicity and whatnot. We can find that by changing the formulation, that can actually help us out. So for instance, by going from a solution to an ointment, that will stick around for longer just because physically it doesn't have, it's much less, or it's much more viscous and will not flow as well. So that can be one way to help out. And in some cases, we can even give like, we can even have means of blocking the tear ducts, either with like a plug or actually cauterizing it closed. And that could be good for someone who has like kind of chronic dry eye due to like, you know, autoimmune conditions or something like that. And you can see here kind of how the nasolacrimal drainage actually occurs here. And you can imagine a lot of blood vessels around here that can absorb. And also one of the big things you'll see with a lot of eye products too, they'll complain about is like bitter taste. And that's again because that nasolacrimal drainage kind of draining out into the back of the throat. So they can have some degree of taste as a result of that. So they complain of bitter taste or something in the eye. That does make some sense based on just how the flow of fluids are going to be going here. Okay. So that's where we're going to see a lot of the systemic absorption that actually avoids first pass, so that actually does help have bigger levels, which may mean more side effects. And I'll talk about a few examples of that a little bit later on. Now, in terms of drugs that need to work by crossing the cornea, you can see here that, you know, there can be some lag time with this, especially based on things like Fick's law that we talked about before, right? So we can't really do anything about surface area necessarily, but we do know we're dealing with thin membranes. But the more lipophilic something is, the easier time it's going to have to cross over. So again, I know most of you probably try to block out most of pharmacodynamics, but this stuff does come back from time to time. I didn't teach it to you just to make you suffer. That was one of the reasons, but there were many others in addition to stuff like this, right? So let's look at the distribution, what happens here. Normally, once these drugs get systemically absorbed, they'll just get distributed like they would via any other route here. Although it's interesting that some routes can actually accumulate in the eye. Here's an example of the drug chloroquine, which is the chemical, you know, cousin to hydroxychloroquine, if you're familiar with that one. It can actually concentrate in the retina and actually causes bullseye lesion there, which is kind of interesting. I'm not sure if that has any specific downsides to vision, but I imagine it's not great for the eye. There is a limited amount of metabolism that happens in here, and that can be useful for some drugs that actually are prodrugs in the eye. So when we get into talking about things for glaucoma, for instance, drugs like latanoprost actually get turned into prostaglandin F2A, for instance, there. But then once they get systemically absorbed, they'll be eliminated through the liver and the kidneys just as normal there. So let's start off by talking about our ocular antimicrobials. Now, again, people coming in with eye infections, for the most part, as long as it's pretty limited and it's mostly preseptal, typically topical antibiotics are beneficial. One, you can achieve pretty high concentrations right there at the eye to treat that infection. And two, it limits systemic bioavailability, such that the patient's not being exposed to a lot of that and all the side effects that come with those antibiotics. However, if it becomes post-septal, you get this orbital cellulitis that starts to develop, the topical antimicrobials just aren't going to cut it anymore. They can't really get to the site of infection quite as well. And so that's where you're going to see that systemic antibiotics may have to be used here. right? And so again, if you think about common bugs that could be causing issues here, you can see things like gram-positives that are coming in from our surrounding tissue, surrounding skin. So you will see a lot of things like clindamycin being used here, a lot of rocephin being used potentially, just depending on what kind of bugs they think are present. Although we'll see that certain things like even contact lenses can affect this too. We'll see in a little bit. So anyway, looking at this, we can see that, depending on what else is going on here, depending on preceding trauma, perhaps that could predispose them to certain types of infections. We're going to see most of these infections are viral in nature, which of course would not really lead us to use antibiotics, but we'll see there may be a few exceptions here and there. Where you start to think about other issues that pop up could be like with immunocompromised patients. So they may have more risk for like things like fungal eye infections, for instance. How involved the disease may lead you to think more kind of risky bacteria and pathogens. So those are things just to consider. So you'll see that the actual microbiologic spectrum will change over time, and as I mentioned before, that it may require either oral or parenteral therapy, especially depending on how severe it is. Oftentimes, vision is one of those things you want to be a little more proactive on because you don't want someone to go blind on you because permanent disability for them. But for those small, mild peripheral infections, that's where we're going to talk about the topical drugs here. Again, they have limited systemic bioavailability. They get really high concentrations, which actually overcomes much resistance. They really don't see a lot of resistance to ocular drugs, which is kind of nice. However, downside is they do require pretty frequent dosing. So taking something like 1 time a day, twice a day, you may be applying these every 4-6 hours, right? Which can be pretty frequent for most patients. We typically stick with broad spectrum drugs, even though we're going to find that for the most part, we don't do a lot of cultures to try to streamline therapy because we're using them locally and they get such high concentrations that it's going to kill pretty much anything that's growing there, unless it's some very specific pathogens, things like Pseudomonas, as we'll see in a little bit. And again, unless you have someone with like immunocompromised immune system or something like that, like typically we don't get cultures unless we're really expecting something odd to be growing there. So when looking at some of the conjunctivitis, again, you're going to see, this mild hyperemia. You're going to see this purulent discharge potentially. Most of the time, it's going to be viruses, right? And so there's not a whole lot we can do for that necessarily. But other things that can come into play here include allergies, contact lenses. Think about where the patient works. Even you might consider maybe there's environmental irritants they could be dealing with that could be leading to some of this conjunctivitis. Not always going to be infectious in nature. You can even see though in some cases that it could be medication related, things that tend to dry out. Patients like antihistamines even could cause conjunctivitis by drying out the eyes. Tumors, things like that. Really a lot of things that can cause conjunctivitis. In terms of infectious pathogens, here's the things you want to think about consistently. A lot of these already have shown up with our talk of ENT stuff. So things like strep pneumo, H. influenza, Marxella catarrhalis. You start to consider staph a little more likely just due to the surrounding skin, which may have been a source for that infection there. And so the goal here is try to eradicate the infection if we can and prevent any kind of long-term complications for them, right? And so here are the list of drugs we're going to be covering here. Most of them we've already seen before. And so you should already know something about them in terms of like mechanism, in terms of how they're going to be acting here. Even if we haven't seen it before, you should be able to make some intelligent, some critical leaps in logic here to understand something about it. So for instance, we haven't seen gadifloxacin before. If you think about it, what does gadifloxacin sound like? Well, it sounds a lot like levofloxacin. And you already know that it works on things like a topoisomerase. Maybe it has some pseudomonal coverage, and we see that in just a little bit. But these are the ones I want you to know in terms of antibiotics, specifically used in the eye. Notice these are all the topical preparations. I'm not talking about any systemic uses for these because that's going to go back to what we talked about in the bugs and drugs section first off, right? So first off, let's look at our macrolides. These are probably some of the more common ones you're going to run into. Erythromycin being much more frequent than azithromycin. Azithromycin tends to be much more expensive, so erythromycin gets used probably 9 times out of 10, right? Remember how it's working by blocking protein synthesis in the bacteria itself by working on those ribosomes there. Again, typically used for kind of your run-of-the-mill bacterial conjunctivitis. For the most part, in terms of side effects here, I'll point out the unique things, but for the most part, eye irritation, hypersensitivity are your most likely side effects. And again, anytime you're putting something into the eye that normally doesn't belong there, your risk for eye irritation, hypersensitivity is going to be there. So just know that's going to apply pretty much to everything we talk about here. So erythromycin typically comes as an ointment, in which case you're not going to be dosing it in drops necessarily, but usually as in inches or centimeters potentially. I guess if you're dealing with, patients in the US, that's probably going to be more inches just because we don't really do much of the metric system outside of science and medicine. You'll see here, 2 to 6 times per day, depending on the severity of infection. And again, this can be difficult to keep up with from a compliance standpoint. So do just be aware of that, if a patient, you don't really expect them to keep up with 6 times a day, maybe consider that to be, maybe 4 times a day they could keep up with reasonably, and that maybe is going to influence your prescribing. Azithromycin comes as a suspension here. It's going to just be 1 drop twice daily. Notice here you still do the same sort of loading dose as what we saw with oral usage, right? Remember we talked about using loading doses to get the steady state a little faster. In this case here, they do 1 drop into the eye twice daily for 2 days and then 1 drop daily. So it's kind of interesting how the ocular administration kind of reflects what we do with oral azithromycin administration. Again, don't know the specific dosing here, but just know that if I have an eye ointment, it's going to be dosed in inches in length rather than something that's a liquid. We're going to be dosing in drops typically, right? The same thing goes for otic medications. Drops is the most common thing we're going to see there. Now, one thing you're going to see is that erythromycin may be overprescribed for patients, even if we strongly suspect they might have a viral infection, mainly because the ointment itself can be pretty soothing to an inflamed eye, so it kind of helps with those symptoms there. They may have a bacterial infection, probably is going to be virals, but again, resistance is not so much of an issue because the concentrations are so high. But this is one of those rare instances where I say, well, even if they don't have a bacterial infection, it's probably not going to hurt, right? There's some other things you could use potentially, but just in case it is bacterial, erythromycin is totally fine. And as I mentioned, azithromycin is going to be much more specialized, much more expensive. You probably won't use it all too frequently. Next, we have trimethoprim polymyxin B, or polytrim. Remember, this is a combo product. We have one that's working, the trimethoprim working on the folic acid utilization pathway for the bacteria, polymyxin B being one of those polymyxins that can directly affect the cell wall. So pretty good combination here. Again, what are we going to be using this for? Typical bacterial conjunctivitis, no specific indications here specifically. Use specific a few too many times, but you can see here this may be an alternative, but keep in mind if someone has, actually goes for the next one, but sensitivity could be an issue here, but if they couldn't receive erythromycin, maybe this is a decent alternative. Look at pricing. It may influence you to pick one or the other. No real clear evidence for one working better than the other one. Okay. Now, sulfacetamide you can find by itself, either as an ointment or solution. This one is, again, working on that different step of the folic acid utilization pathway as opposed to trimethoprim. Remember, though, this one, if a patient does have a sulfa or sulfonamide allergy, you do want to avoid this because this can have a reaction there with those patients there. It should cause an allergic conjunctivitis in addition to the bacterial conjunctivitis they already had. Okay. So again, and maybe if a patient was on erythromycin previously, and they came back and the eye infection is still sticking around, that's where you may switch it up to one of these other ones, things like sulfacetamide or polytrim or something like that. Next we have bacitracin. Now most of you probably are familiar with bacitracin being used topically for cuts and wounds and things like that. So this is actually the same product here. It actually works on cell wall synthesis, right? So kind of another cell wall active drug that we didn't mention previously, because bacitracin itself is pretty toxic when used systemically, but when used topically, either on the skin and the eye, not a lot of issues there. The only time you'll see bacitracin being used internally is for, sometimes they'll do it for like washouts of wounds sometimes, or surgical sites. That's used occasionally. So if you work in surgery, you may see that there. All right, so next we have the fluoroquinolones. These ones here, you're going to use pretty on a more limited basis. The reason why we want to hold off on using these is because they tend to have pretty good coverage against Pseudomonas. And so unless you suspect the patient has a pseudomonal infection, you typically are not going to want to bust these out, okay? In this list here, we have things like ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, and then gadafloxacin. They're all going to work very similar in terms of their mechanism, all the same issues. Notice here, though, we're not just using it for conjunctivitis, but also if they have corneal ulcers, that can be another case where this can be really beneficial for them too. In terms of side effects, so again, unpleasant taste, usually due to nasolacrimal drainage. You can see a white precipitate with like ciprofloxacin, which they may think is some kind of discharge or something. That's just related to the drug sort of drawing out and seeing some residue left over from that. So nothing too concerning from that standpoint. Again, pretty well tolerated, but this is going to be more so when we're looking to treat corneal ulcers, or if they have like pseudomonas. And when do they have pseudomonas? You probably know this, but when we're thinking like contact lenses. So that history wearing contact lenses and coming up with this conjunctivitis, your suspicion for pseudomonas goes up pretty significantly. That's where you may bust one of these out. They tend to be more expensive, and even when used topically, they are starting to see some emerging resistance. So you got to be very judicious about when you're going to bust one of these out here. Okay, going to be frequent dosing here. Another thing to note too, for patients who are contact lens wearers, while they're taking these antibiotics here, they cannot use their contact lenses until the symptoms sort of resolve, and then they can go back to using them. Make sure they use a new pair, or they have thoroughly cleaned the old pair. Don't want them to go back and get another infection for the same thing. Isabel says, cornea surgeon I worked with would prescribe every cataract surgeon LASIK patient Vigimox. There you go. Doing something like that is a little more invasive, so maybe they're trying to cover their bases a little more and use it for that. So that could be one reason for that, for sure. Yeah, so Vigimox isn't a big one. It's kind of expensive, which is kind of a downside for some patients, but it definitely does its thing pretty well. Aminoglycosides can be used here too, like gentamicin ointment, tobramycin used most commonly here. These are going to be other ones that also have good activity against Pseudomonas, so these may be kind of like a second line for as opposed to the fluoroquinolones. Only issue here with these is that they can actually lead to more corneal ulceration. They actually cause ulcerations themselves after a few days, and some of this kind of reactive keratoconjunctivitis. So they're pretty irritating on the eye, which is why they don't get used quite as frequently. So that's one thing you won't see as often. And again, you can kind of refer back to these mechanisms here in terms of where they're working at. You can see that there, so no point in belaboring these points here. So let's talk a little bit about ocular antiviral drugs. Again, if you're suspecting patients have things like retinitis, herpes zoster, ophthalmicus, a lot of these you're going to find if they're in immunocompromised patients, we're typically going to be switching over and using more systemic therapy. But I am going to focus on the limited number of ones we have in terms of topical use. Now, if they have like a viral conjunctivitis due to stuff like adenovirus and things like that, there's not a whole lot we can really do about that. I'm talking about things like herpes zoster, those are going to be the things, CMV, things like that are going to be things we can actually have drugs that are being very effective against that. So the ones that I highlighted here are the ones that I'd like you to know, because if you notice, all these other ones are going to be systemic drugs that we've already covered for the most part. Again, if you're thinking a patient has very advanced disease, if they're developing things like these herpes zoster, ophthalmicus, they probably need more systemic therapy, because chances are they probably have some degree of immunocompromisation, if you had to guess. But there are a few that are given actually topically, or as the case may be, as an intravitreal implant. So the first one we have here is trifluridine or Viroptic. This one is working similar to what we saw with some of our other agents there in terms of, for instance, how our flucilidocin worked for fungal cells. You can see here this actually works on the virus by preventing that thymidylate synthase, so it can't produce new nucleotides in the DNA itself. So kind of work through that similar mechanism there. Normally used for like herpes simplex viruses causing that keratoconjunctivitis. The big thing to note here, the big side effect that is kind of unique, is you can get this punctate keratopathy, which is sort of unique. So that's why I draw attention to that there. Otherwise, pretty well tolerated besides some ocular irritation. Now, ganciclovir, we talked about previously as being sort of that false nucleotide that acts as that chain terminator, gets incorporated into the viral DNA, and then it can't add anything onto it because it's missing that sugar molecule that's normally attached to the nucleotides, right? This is going to be more for like cytomegalovirus retinitis, maybe herpetic keratitis occasionally. This is where we see that intravitreal injection or the intravitreal implant that allows for kind of long-standing, and you'll see that more in patients with severe immunocompromisation, like kind of late-stage AIDS and things like that. So this one can also cause a punctate keratitis, but not as notable as the trifluridine. So you can see what one of these implants kind of looks like. You see here the kind of the tablet kind of slowly releasing the drug over time being attached there in the eye. I don't know if they can actually feel that or not. I would not imagine, so there's probably not a lot of nerve endings there, but the any of the eye stuff, especially like in horror movies, it really kind of freaks me out. So this is kind of uncomfortable to look at. So I'm just going to keep going forward. In terms of antifungals, this is another case too where if patients are having a fungal eye infection, something else is probably going on, especially more systemic in nature. And so these are going to be like in patients who are immunocompromised that probably need systemic therapy, things like the echinocandins or amphotericin B, things like that. Other people, though, who may be more at risk for fungal infections include they have like a trauma, especially any kind of penetrating trauma. If they have something like contact lens wear, or this is a case too where we saw a topical steroid use. There are going to be some ophthalmic steroids we'll talk about in a little bit that can actually cause some local immunosuppression that can increase the risk for fungal infections. That could be, you want to look at what the cause is for that to see how systemic you need to get. In terms of this, all of these that we've seen so far are actually going to be either intravenous or oral agents we've looked at previously, or some of these are going to be like specialty compounded products. So things like this, amphotericin B topical solution, they don't just make that. No company makes that. You'd have to go to a compounding pharmacy to have it specially made. And so I'm not going to have you memorize all of that necessarily. It's kind of outside of our scope. There is one, though, that comes as a commercially available product here, which I've highlighted, which is natamycin. You can see here that's going to be working basically to increase that cell membrane permeability by binding to sterol within the actual fungal cell membrane. So it kind of disrupts that. I wouldn't memorize specifically which fungi it works for. Just know that it's going to be useful for fungal ocular infections there. And no real side effects to mention. Okay. So, of course, when you have these patients who are coming in for ocular complaints, you always want to document visual acuity to make sure things are not going in the wrong direction, right? You want to be able to make sure you document that. So when the patient comes back and they say their vision's worse and they say, well, it's because you didn't treat me well, you can actually look at a pre and post to see what's going on there, right? Make sure to look for allergies. Make sure to keep the exam dates available and know when they happen and what the results were. Make sure they're doing a follow-up to see if their visual acuity is getting any worse there. And obviously, you have to know when you're sort of outside of your scope. And so if things are getting worse and going in the wrong direction, always just reference back to ophthalmology, get them on the phone and see what they want to do. So how do we administer ocular medications here? So obviously the first step is always going to be wash your hands with soap and water. This is probably the most important step to prevent any secondary infections there. And basically the big thing here is you want to keep the bottle as sterile as possible, right? This is more important for ocular products than it is for like otic products or any other liquids you're going to run into because we are kind of putting it into a very protected or very susceptible site to infection. So avoid touching the dropper to anything. Should be remaining sterile as possible. That means no sharing with anyone. Making sure they're not touching the bottle tip. Just trying to keep it as sterile as possible. Then you're going to have them tilt the head back. Pull down on the lower eyelid to form this little pocket here, which you can see. And so then we're going to hold the dropper and place it down here into the cul-de-sac here, and do one drop typically at a time. If you do more than that, the risk for having it kind of flush out is too high. So typically one drop at a time is going to be helpful. This will also be important when we're talking about multiple different drugs at the same time, which will be more so when we were looking at like glaucoma treatment there. Once they're done, what you can have them do is actually close the eyes and tilt their head forward, and they're going to place their finger over the lacrimal duct. The benefit of this is that it prevents it from being flushed out through the nasolacrimal drainage, and that can go ahead and help keep the drug around for longer. So they're actually helping to get more bang for their buck, keeping that drug in contact with the cornea for longer to allow it to do its thing. Have them do it for 2 to 3 minutes, which some people are not going to be able to do that, but we tell them that. And then once they're done, they can wipe the excess and then wash their hands again. So this is kind of the standard recommendation for how to actually apply the eye drops for these patients here. In terms of drops versus ointments, ointments tend to be better for kids, mainly due to the poor compliance. I can barely get my kids' teeth brushed. And imagine putting any kind of drops into her eye would be nigh impossible unless I have like 3 adults to hold them down, right? So ointments are good because even if you were to get the ointments onto like the eyelashes, that can still get decent contact with the eye itself and wouldn't be flushed away just like a normal suspension or a solution would be. So ointments can be better for that. Keep in mind though that it will blur the vision more so. And typically tell them don't drive, don't do anything until they have more clear vision, right? This is for your adult patients. I can't imagine any children driving, or at least I hope not. For the gels and ointments, again, you're going to be doing a similar process. You don't have to cover the nasolacrimal duct because it's going to be much more viscous. There's no flow there. And basically they'll squeeze that ribbon of medication. Now, if you tell them 1/2 inch and it's like 3/4 of an inch or 1/4 of an inch, like it's probably not going to matter a whole lot in the grand scheme of things because again, how well can you really estimate the distance there? But again, as long as you're close, it should be fine for the most part. If you have patients with contact lenses, again, they should discontinue use and make sure they don't use them again until the eye's not inflamed. There's no discharge for about 24 hours or so, and hopefully they're going to discard and get rid of the old lenses there because could lead to reinfection, right? And unfortunately, I know this hurts. Got to get rid of the eye makeup. They mentioned this, you know, so even if it's the expensive stuff, it could have been infected, and so you can then reinfect yourself with your, you know, trying to get your smoky eyes or whatever. I don't really know much makeup terms, but that's what they recommend. So sorry if you have the expensive stuff, but that's what they say. Does anyone know what to do if a patient were to get their eyes glued shut with super glue? Good question. They call that cyanoacrylate blepharospasm. The actual term for that super glue is cyanoacrylate. This is a case to where I've seen kids do this before. They'll accidentally get their eyes glued shut. Normally, it's usually most of the eyelashes that are kind of glued to the skin. You can use things like erythromycin ointment. The benefit of doing that is not because there's any bacteria there, but it's because the kind of the lipophilic base that it's in, sort of that, it's kind of like a white petrolatum kind of base, helps to break down that, helps to break down the bond there with the super glue. So you can just apply that onto the eyes. They'll probably be fighting you for it, but you can do that, and that will help them then eventually loosen it up, and then they can see again. So, and then you recommend don't put super glue in your eyes because you have to come back and do that again. So let's talk about ocular allergies here next. You'll see there's going to be a lot of crossover with the type of drugs, or at least the mechanisms that we're talking about. So again, similar mechanism here, right? You're seeing the same histamine being released. You're seeing the same mast cells degranulating, causing all of these effects here. And so you get the same redness, swelling, itching, all of that happens there. Because that's saying, do you need the erythromycin ointment specifically, or can you use petroleum jelly? You could probably use either. I would stick with the erythromycin ointment because it is formulated for the eye specifically. If you had something else, I can't think of any products off the top of my head, but are in that sort of ointment base, that would also be fine. Yeah, so your guys' trivia game is going to be just off the chain. If you ever get asked esoteric pharmacy or tox questions, I'm the person to come to for all of those. Let's see here. Next off, so again, looking at the allergic cascade, you know, this is exactly what we saw before in terms of causing the vessels to dilate, and they are leaking fluid, and at least that swelling, the tearing, the histamines causing the itching, all of that. So the techniques we're going to use to help prevent that are going to be the exact same. We're going to do the same things here. So for instance, we can block the H1 receptors. We'll just be using something in the eye directly. Now, this used to come before the ENT section, for the reason I put it third. So we talked about the physiologic action, so we already know about that. So I can just actually just delete that if I wanted to, and just say, no, we already talked about that. We already got to it. But the same action here, just like they would do in the nose, they're going to do the same thing here. There are a lot of them throughout here. So we have things like a zealostine, which we saw before is being used in the nose. We'll have betotastine, we have imidastine, ketotifen, olopatadine. Ketotifen is notable because it's available OTC. Now some of these have what they call mast cell stabilizing properties, right? The MCS, so preventing mast cells from actually degranulating in the first place. This is helpful, especially if you're taking them sort of before the allergic reaction happened, right? So if they're taking them, say, before they get exposed to whatever their allergen happens to be, whether it's a dog or pollen or something like that, that can help to prevent some of that degranulation and can mitigate some of the effects you're going to see there, right? Now, in terms of dosing, again, some people will use this more on an as-needed basis. So once they're already having the reaction, they want to use this. Some people know to take it sort of prophylactically if they're very likely to have reactions due to seasonal effects or if they're around certain triggers or something like that. Note in terms of adverse effects, the biggest thing is you can see increased dryness, which makes sense because of their antimuscarinic effects. They can then cause drying to occur there. So that may lead to more of the ocular irritation that can happen. So that's one thing to note. Now, these antihistamines are typically preferred over pure mast cell stabilizers. And I'll show you a few examples of those. The problem with pure mast cell stabilizers is you have to take them before the insult actually occurs in the first place. These won't do anything if the mast cells have already destabilized. But while I'll mention them here, they're not going to be used as common, but they may be better for patients who can't tolerate antihistamines and may want to take something sort of around the clock to try to prevent these reactions from happening if they know they're going to be in a situation where that can occur, right? And notice any of these agents here I'm talking about now, they work fairly immediately as soon as they're in the system, as opposed to like the corticosteroids, which do take time to work, right? So be aware of how the mechanism is affecting the time to onset. Like if I have a bunch of histamine floating around and I add an antihistamine, it's going to work pretty much immediately versus something like a steroid that takes, days to weeks to work in some cases. There are three we have in this category here of mast cell stabilizers like cromolyn, lidoxamide, and the netocromel. Again, not used as commonly, but can be useful alternatives, but they got to be used before the actual insult occurs. Once they're already having all that redness and itchiness and all of that, it's not really going to do much for them. Pretty well tolerated, some irritation. It's mainly the lack of efficacy for existing symptoms that are kind of limiting its use for the most part. All right, so some other things we can do. Things like vasoconstrictors and antihistamines as a combination being used to help deal with a lot of that redness and that swelling. So just like what we saw with oxymetazoline being used for the nose to decrease some of that congestion, we can do the same thing for the eyes as well. So we have things like tetrahydrozoline, we have nefazoline, and we have phenylephrine, which phenylephrine actually is an antihistamine. If you recall, we talked about chlorpheniramine being used orally. And then we had this in combination with nefazoline here, okay? These tetrahydrozoline and nefazoline do the same exact thing as oxymetazoline does, and they all have similar names there. And so they're going to be activating those alpha receptors in the eyes to cause constriction of the vessels to decrease the swelling, decreasing the edema. The phenylephrine can help out with the itching from that standpoint. All very helpful here, right? Remember though, like we said with the nose, you can see that rhinitis medicamentosa. You can also have rebound hyperemia due to use of these drugs here, okay? This is a really good counseling point for patients because if they keep using it all the time to try to get rid of that redness, they're going to see rebound redness and swelling as a result of abrupt discontinuation. So probably would not use this for more than 2 weeks in most cases. Not quite as quick of an onset as what you saw with Afrin, but I would definitely use less than 2 weeks here. Now, what you're going to see with a lot of these OTC meds, because patients may be self-medicating without really talking to a provider, if they don't see any improvement within like 72 hours, they need to discontinue and see somebody because it could be something else going on. It could be bacterial, it could be a fungal infection, it could be any number of things. They need to get evaluated and ruled out before things get worse, right? Especially with the eyes, you want to be really careful with that. Now, what's interesting is that the oxymetazoline, tetrahydrozoline, nefazoline, they all fit in this category of what we call the imidazoline derivatives. And so this is actually going to be important in a little bit when we talk about some of our drugs for glaucoma. While locally they act on the alpha-1 receptors, systemically they actually get into and they can affect the alpha-2 receptors. And if you recall back last semester, we mentioned alpha-2 receptors are what we call autoreceptors. And autoreceptors, when activated, will shut down the release of the neurotransmitters that would normally activate it. So in the case of alpha-2, it shuts down norepinephrine release. So what does that do in the brain when you cut down norepinephrine release? Well, it shuts down the sympathetic nervous system, or it starts to decrease its activity. And so this is actually a really important thing because we've seen kids who will actually get into this because you have parents around, they're taking tetrahydrozoline for ocular congestion, things like that. And all of a sudden their kid gets into it and drinks it, and it doesn't even take that much. They can get severe sympatholytic poisoning where they get bradycardia, hypotension, CNS depression. There's been cases of death from that. So you gotta be really careful, making sure even though the stuff seems innocuous, is over the counter, can still be really dangerous, especially for little ones getting into it, okay? So up next, let's look at our steroids here, which can help out with inflammation. These are not going to be regularly used for most patients with inflammation. Usually stick with antihistamines and things like that. But these are going to work just the same as they do systemically by blocking the activity of cyclooxygenase, right? They're going to decrease prostaglandin synthesis, thromboxanes, all of that. These are more so used for things like post-surgical reasons, right? So use this in patients who may undergo ophthalmologic, I can't even say the word anymore. It's too late in the afternoon on a Friday, my gosh. Eye surgery, I can say that, can decrease that inflammation there and can be useful for dealing with pain and things like that. So a couple of the ones we have here include bromfenac, diclofenac, we have flurbiprofen, we have ketorolac or ketorolac. I say ketorolac most of the time. If you hear toradol, that's the parenteral form you typically use. And then nepafenac. And so, as I mentioned, usually for post-operative inflammation and pain, not typically used for run-of-the-mill conjunctivitis, right? You can still have some activity in allergic conjunctivitis because they're still decreasing the amount of prostaglandins being produced as a result of cyclooxygenase, but not as often, right? And of course, the reason why we don't like these so much is one, they can cause pretty significant keratitis. They can increase the intraocular pressure, which is not great for patients with glaucoma. And they can lead to some things like delayed wound healing and things like that potentially. So not great. So try to limit use if we can. Similar to how we have NSAIDs and then glucocorticoids for systemic purposes, we also have glucocorticoids for the eyes as well. And so these are going to be helpful because, again, they can help for more kind of long-term control of inflammation, as we'll see there. And so you typically will be using these for like surgical purposes for the most part, or these are going to be more things like they're going to be prescribed by your ophthalmologist, not necessarily you if you're working more like in emergency medicine, urgent care, family practice sort of thing there. So it's much more specialized for the most part because they can have some significant side effects, as we'll see there. And so sometimes we'll actually have our ophthalmologist who will do things like intravitreal injections of things like dextromethorphan, things like that, but they can also be used topically occasionally. As we talked about glucocorticoids already, you can see all the different actions they're going to have to help decrease inflammation. So I won't belabor this point too much. It's kind of nice when there's a lot of crossover between these topics because I don't have to repeat myself a ton, even though I like to repeat myself. But so what you're going to see here is that these are best for patients who are having really refractory symptoms, so they couldn't tolerate NSAIDs or antihistamines, and these are kind of your last stop here. The reason why we don't like them, especially for more long-term use, is issues of things like cataract formation. They can lead to elevated intraocular pressure, especially if they have a history of it or a family history of it. They're going to depress the immune system, so infection risk is going to be higher, wound healing is going to be impaired, and you can see corneal ulcers develop. Right? So for the most part, you're going to be using very limited courses here, like less than 2 week, what we call pulse therapy. You're kind of giving a pulse of drug over the course of like a week, 2 weeks, and then you discontinue it. I'm not too worried about systemic effects from this ocular glucocorticoids, especially with relatively limited time use here. So really just the ocular problems, what we're worried about with this one. The ones we have available, is actually quite a few of them, some of which we've seen before, include things like dexamethasone, prednisolone, difluprednate, and there's actually 3 here that I'm going to mention that have these asterisks next to them, so they're a little bit different. They call them soft steroids, and they actually have a decreased risk for causing intraocular pressure issues, right? So if you had a patient with glaucoma, these would be the better ones to use for them. So things like fluorometholone, loteprednol, and then ramexolone. There's also triamcinolone, which is typically used for more intravitreal injections. The rest of these are all going to be topically available. So what do you do for patients with dry eyes? Like, and dry eyes can be caused by a lot of things. Chemical burns, you can cause it due to, medications can do this, lots of things. A lot of autoimmune conditions can do this. Things like, rheumatoid arthritis, even Stevens-Johnson syndrome can lead to this. So a lot of things can lead to dry eyes. What do you do for them, right? First off, if you can get the underlying disease under control, so if they have rheumatoid arthritis, get that inflammation under control first systemically, and that will help out with the eyes there. In terms of physical interventions, you can do things like punctal plugs, which is like a little silicone plug you can place in the nasolacrimal lacrimal duct. You can do things like surgical occlusion where you actually cauterize it shut. That's a possibility here. But because this is a pharm class, I want to focus on the tear substitutes. And so these are typically either like hypo or isotonic solutions that have things like thickeners and surfactants, and basically they're a little bit more viscous than your typical tears would be, which means they have more time in the cul-de-sac. They'll hang out and be able to better kind of hydrate and lubricate the eyes there. So some of the common ones you'll run into include things like, balanced salt solutions, which is called BSS occasionally, carboxymethylcellulose, hydroxypropylcellulose, and polyvinyl alcohol, right? So if you hear like artificial tears, that's what that's referring to. They're trying to mimic what the normal tears would be, but just a little bit longer contact time because these patients are not producing enough tears on their own, right? One thing you could also do is actually provide what they call an immunomodulator, which is kind of a fancy term. I had a role model in school who always said, if you hear someone use the term modulate, something that usually means that it does something, we just have no idea what the heck it does. So it's a good way for people who don't know what they're talking about to sound smart. So I'm going to say here that this modulates the immune system, right? So we have cyclosporin or Restasis. This is the specific brand name we see used for the ocular dosage form here. Cyclosporin, if you ever heard of it before, is typically used for more things like organ transplants, used to suppress the immune system and try to prevent things like organ rejection. Well, if you had a patient who is having dry eyes as a result of autoimmune function, you can end up seeing here that by suppressing that with cyclosporin locally, this can actually help out. So it helps to do things like decreasing the release of things like interleukin 2, so you have less T cell activation, and can really help out. It's not great on the eyes, it's pretty irritating if anything. There's a lot of burning, foreign body sensation that you can feel there. I don't know what domestic body sensation is, but a foreign body sensation is certainly not good. And what you'll end up seeing though is they end up having increased tear production, improved vision and comfort. So that burning is not great, but overall, if it helps out with the chronic dry eye, that can be beneficial. So if all the other stuff wasn't working, this may be a good option for them. All right, so we have some time for sure. Let's talk about glaucoma next. So what is glaucoma? Well, this is basically just elevated intraocular pressure, right? And why is that a bad thing? Well, because by putting extra pressure on that optic nerve, you're going to eventually lead to nerve damage, and you can end up having irreversible blindness as a result of that, right? There's two main varieties, as you might have learned about, open versus closed angle. We're going to realize or see that the drugs we focus on are going to be for open angle glaucoma. Usually closed angle glaucoma is more of a surgical issue. That's more of a much more emergent, got to take care of this right now before that patient goes blind thing. Versus open angle is going to be more of a long-term, years worth of treatment, as we'll see, to try to stave off progressive vision loss. We're going to see this is trying to decrease the amount of damage being done. It's not going to reverse anything necessarily, but helps to kind of keep the vision that the patient has. We're going to see there's two ways we can do this. We can try to decrease the amount of aqueous humor that's being produced here. No, there's nothing funny about that. And then the other way we can do that is to try to increase the outflow of that humor through the trabecular meshwork. We're going to see that drugs either work one or both of these mechanisms here. And so that'll be good to know because we'll know how we can combine these drugs together to maybe get some synergistic actions, as we'll see in just a little bit. So normal pressure, somewhere between like 10 to 21 millimeters of mercury, and we'll see that any pressures higher than that tends to lead to kind of progressive optic nerve damage, as we'll see there. And again, typically with open angle glaucoma, it's usually more as a result of either increased production of aqueous humor or it just can't get out, which is why our drugs are going to work through one of those two mechanisms there. Whereas closed angle glaucoma is basically going to be an actual direct physical blockage there, which is why it's more of a surgical issue that usually is going to be presenting with a lot of acute pain. Many patients don't know they have glaucoma if it's open angle because they just don't really feel it, right? You can kind of see the difference here between these two. With the closed angle, you can imagine that immediate pressure buildup being a big issue versus here with the open angle, it's going to be more of just kind of a slowing of fluid coming out, either too much being made here or too little flowing out, right? So looking at this, we can see with ocular hypertension, our goal is to try to either decrease what's being made here in the ciliary bodies or try to increase this amount of outflow coming through the trabecular meshwork such that it can go down the Schlemm's canal, which is one of my favorite body parts ever, just because it's fun to say Schlemm. And so we'll see that the different medications we choose will work via these two mechanisms, and we're going to see that which ones we pick can be based off side effects, overall efficacy, and things like that. So here's how we delineate these two categories here. So to increase aqueous outflow, we're going to have our prostaglandins, which are going to be some of our first-line agents. We're going to have our alpha adrenergic agonists, which are going to be similar to some of the other meds we looked at today. Some cholinergic agonists. And then we're going to have, to decrease the aqueous production, we're going to have our alpha adrenergic agonists. So we can see here they do both. We're going to have our beta blockers. And then we're going to have our carbonic anhydrase inhibitors. So this is going to be interesting because carbonic anhydrase inhibitors also uses diuretics, but we'll see why that is in just a little bit. Frequently, you're going to need multiple agents here combined together to get synergy, to get that IOP under control. Let's start with the prostaglandins first. These are going to be agents that are sort of mimicking the actions of PGF2A. And basically, by binding to prostaglandin receptors in the eye, you're going to find it will then increase that outflow to help get that pressure under control. Some of it is probably due to things like ciliary muscle contraction being altered. Maybe we have like some changes in those meshwork cells. We don't really know. We just know that it works, right? And that's usually good enough for us. A couple of agents that fall into this category include latanoprost, travoprost, bimatoprost, and then tafloprost. Tell if it's a prostaglandin because it has a prost on the end of the name there. And bimatoprost I've mentioned briefly before because remember we talked about Latisse being used for eyelashes, so that's good to know in terms of side effects there. Some other common ones we'll run into include things like conjunctival hyperemia, You see some irritation, those changes in eyelash length, which could be beneficial to some patients, and actually a change in the iris color, which is interesting. We like these because it's pretty effective and it has very limited systemic side effects as compared to some of the other agents we'll see here in just a moment. Here's an example of what this looks like between someone who has taken a prostaglandin in one eye versus the other. You can see here that they have significant darkening of the retina here, not the retina, the iris here, such that it is, if you had someone who had pretty blue eyes before, maybe they don't want brown eyes. I think brown eyes are great. My wife has brown eyes. But, it just depends on what the patient's preferences are. And so this may lead you to not choosing this one off the bat, depending on, what the patient's, sort of priorities are there. Here's an example of using that side effect, though, of lattice with bromatopros causing the increase in lash length there. So now, oftentimes, especially if you work, depending on where you're working at, you may see this being used for more aesthetic purposes than you do for glaucoma specifically. And one thing to note here is that you don't want to exceed once daily dosing. It's kind of interesting that you actually end up causing inhibition of the IOP lowering effects and can end up worsening the glaucoma for patients who get more than just that one daily dosing. So just stick with that, and that's all you need. So second line, and for patients who maybe don't want to take a prostaglandin first line, they could use this as first line, are going to be our beta blocking agents. And you already know what they do, just based off the name. They block the beta receptors, right? So by blocking those beta receptors, you're going to see less catecholamine activation due to things like norepi and epinephrine, and they will decrease cyclic AMP, which is an important secondary mediator in those activations there. And overall, you're going to see less aqueous humor production. Whereas prostaglandin's increased outflow, these will decrease aqueous humor production. So it would make sense to actually combine these two together potentially. You can do a prostaglandin plus a beta blocker, and they would work synergistically on these two different mechanisms. That can be helpful. Now, to get into talking about beta blockers, it's important to know that about the concept of selectivity, which I know I've talked about before, but we don't just have one type of beta receptor. We know we have at least 3 beta receptors, 1, 2, and 3. And beta 1 we know is really important for its effects on the heart. Beta 2 we know is really important for its effects on the lungs, for instance, and that bronchial smooth muscle. Beta 3 probably has some stuff to do with lipolysis and things like that, so we don't worry about that too much. But it's important to know whether your drugs you're dealing with are selective versus non-selective. Non-selective drugs are going to act on both beta 1 and beta 2 with no preference for one or the other. It's just going to work on both of them. On the other hand, beta 1 selective agents are going to primarily work on beta 1, have very little beta 2 blockage, right? Blocking activity there. So what does that mean for us? Well, that means you can have a little bit different idea in terms of side effects you may experience by preferentially selecting one versus affecting both of them. So we'll look at those differences there in just a little bit. So in terms of beta 1 selective ones, we have metaxalol, you see there, and then in terms of non-selective ones, we're going to have cardiolol, timolol, and then levobunolol. If you see the OLOL at the end of the name, chances are it's going to be a beta blocker, okay? Propranolol, metoprolol, things like that. Anyway, you tend to find that the non-selective agents are going to be more efficacious, but they tend to find more side effects. The reason why that is because there's more beta 2 receptors in the eye, but you will see some decent systemic absorption of these drugs here. What does that do systemically? Well, as you might imagine, it can affect the heart, it can affect the lungs, it can affect anywhere beta receptors are once they get systemic. So in terms of beta 1 effects, what would you expect to see by blocking those beta receptors? Well, you'd slow down the heart rate, maybe lower the blood pressure to some degree, okay? Heart block could be caused through this. You could worsen someone who has a history of heart failure, right? Most of these patients with glaucoma are a little bit older. Maybe they have coexisting CHF to go along with this. Maybe that's not a great option. That's going to happen with any of them in terms of cardiac effects because either one of these are going to be affecting beta 1 receptors. Now, if you have someone who has a history of asthma, who may be predisposed to asthma exacerbations as soon as you start blocking those beta 2 receptors, then that's not going to be good for them. That would be a case where if you have a history of asthma, reactive airway disease, stick with your beta 1 selective agents because you're going to spare those beta 2 receptors. Because we'll talk about this in the pulmonology section, but how do you treat an asthma exacerbation? We give them a beta 2 agonist. If you're blocking the beta 2 receptors, and that's going to limit how effective those drugs are going to be. You got to be cautious with that. Make sure you know what the patient history is and make sure you're not going to be giving them something that's going to cause an issue, right? So again, this is basically what I was talking about there. Non-selective beta blockers will hit both. Selective beta blockers will hit beta 1 preferentially, have very little activity of beta 2 receptors, okay? So it should spare the bronchial smooth muscle, and things like albuterol will still work just fine. All right, up next, we have our alpha adrenergic agonists. And so these are going to be things that are alpha 2 agonists. And so what that means is that they're going to be acting on alpha 2 receptors, very similar to what we saw with tetrahydrozoline and oxymetazoline and all of those imidazole derivatives. They work very similar to these alpha 2 agonists in terms of activating alpha 2 receptors. And as we said, working in the CNS, they can actually end up decreasing either the amount of aqueous humor produced, or they can increase the outflow of aqueous humor through that trabecular meshwork. And so they're kind of working on both mechanisms here, but we'll see there's some side effects that kind of lead them to not being used first line, because it sounds like they're awesome, but you may see that's not going to be the case. There could be some limitations. So the two we have in this category include aproclonidine, which if any of you are familiar with blood pressure medications, if you've ever heard of clonidine before, that's going to be one we'll talk about in the cardiology section, but that kind of fits into the same sort of category here. And then we have brimonidine. And so again, based on the lipophilicity, it's how likely are to see some of these more systemic sort of effects here. Now, as I mentioned, just like we saw rebound hyperemia with afrin, right? We saw rebound hyperemia with tetrahydrozoline and those drugs there. You can get a rebound effect, just like you would see with any of those drugs. So that can happen here with a long-term use if you stop abruptly. And you can see some allergic conjunctivitis. A little less common with the brimonidine, which is notable, but either way, that is a risk. Typically, we don't use this in kids less than 2 because they have a much more, their blood-brain barrier is a little easier to breach. And so you can see things like CNS depression and apnea as a result of those effects. Just like I mentioned a few slides before about how those imidazole derivatives work on the brain, right? And then you're going to see, hopefully in adult patients, limited systemic effects due to the ionization state. So hopefully they're going to penetrate less and work more specifically on the eyes itself. Let's see. So the OTC, brimonidine, Lumify, you get rebound redness. Yeah, so these wouldn't be OTC. So all of these glaucoma medications here are going to be prescription only. But yeah, brimonidine could cause that rebound hyperemia. Any of the other imidazole derivatives I talked about, tetrahydrozoline, they can all do the same thing for sure. Yep. All right. And then lastly here we have the carbonic anhydrase inhibitors. And so this is going to be including 2 agents called dorzolamide and brinzolamide. If you've ever heard of acetazolamide, it also fits into the same category here. And so basically what this does, and the mechanism is a little complicated, but it inhibits an enzyme called carbonic anhydrase. And what does carbonic anhydrase do? Well, it causes interconversion between CO2 and water and can convert it into bicarb. And it can then take bicarb and convert it back into CO2 and water. And why is that important? We'll see in just a moment, but it helps to regulate the flow of fluid. This does it in the kidneys, it can do it in the eyes as well. And so basically what you're going to see is by inhibiting this process here, you're going to decrease that production of bicarbonate ions, and that decreases fluid transport. If you just know that, you're 90% of the way. That's totally fine. I'll show you a picture here in a moment that will probably end up confusing you more than anything. But as long as you know that's decreasing that fluid transport and it helps to lower IOP, you're golden there, right? In terms of adverse effects, though, this one's not great because it's going to cause a lot of burning and stinging and some bitter taste. So again, this is going to be kind of lower on the totem pole in terms of the medication you're going to go with for these patients here. Okay, so here's a picture of what this kind of looks like. So if you can imagine the aqueous posterior chamber here where the water is going to be flowing versus the stroma here. Basically what this is doing is that normally you're going to find that the CO2 and water, they're able to cross over pretty easily there. But when you convert over to bicarb, basically you're not going to be able to move that as easily. So by inhibiting this process here, by preventing the bicarb from being formed, you decrease the amount of water that's flowing through and thus the aqueous humor production goes down. Okay, that's really what you need to know. We'll talk more about this when we get into the kidneys, so don't stress too much on this complicated picture. Just know that by decreasing bicarbonate formation, you're going to decrease that fluid transport. Okay. All right. And then one of the last categories we have here, I thought we were done with that section, but not. You're going to see that the cholinergic agonists can be also useful by helping to activate muscarinic receptors, and then causes that ciliary muscle contraction, which will help to increase outflow. Whereas with the anticholinergics, like diphenhydramine or antimuscarinic drugs, they would cause mydriasis. These are going to cause meiosis, right? And so we have things like acetylcholine, which makes sense because acetylcholine works directly on cholinergic receptors, of carbachol and pilocarpine. You're going to find here that this is not a great set of drugs, mainly because compliance is low, because it causes really poor vision, right? The visual disturbances, headaches, small fixed pupils. It's not great, and the accommodation of the lens is going to be really inhibited there. So due to that, this is really going to be used more kind of last line. Maybe patients who are already legally blind, where this is not going to worsen their vision all that much more. This may be the case where we're going to use that, but typically for younger patients, it's not going to be great, right? Especially if their vision is still pretty much intact. And oftentimes we'll use combination products because that will help to increase compliance, allow us to use just one drug instead of multiples, and that can help to get synergistic lowering of the intraocular pressure as well. So that's kind of the main benefit you're going to see with that. So who to treat? Well, basically, a lot of times if you have patients without risk factors, like a previous family history, you go ahead and monitor them until you start to see some of those glaucomatous changes actually happen there. In patients with positive risk factors, then you go ahead and treat immediately to try to stave off any of those changes. Again, these drugs aren't going to reverse the visual changes that have happened. They're only going to prevent them from getting any worse. And generally, you can start with a prostaglandin analog or a beta blocker. Either one are fine. Probably prostaglandins will be a little bit more effective right off the bat, but given changes in iris color and whatnot, you may not want to do that necessarily. In some cases, you may just try therapy in one eye just to see how tolerable it is, to see how efficacious it's going to be, and then you can switch to doing both eyes. And generally, we're going to shoot for like a 20-30% reduction in IOP, and that's considered to be pretty successful. So I got about 5 minutes left. So what I think I'm going to do, I only got 4 slides. I'm going to go and just finish this up real quick if you guys don't mind. That way we can spend the whole last section just doing our review. So that'll be good. So basically with their ocular anesthetics, the biggest thing here is they're going to be blocking the neuronal signal conduction from occurring, right? So basically they prevent sodium influx into the neurons, and that prevents the propagation of an action potential such that the signal or that sensation of feeling never makes it back up to the brain. Same thing what it does in the skin in terms of anesthetics, same thing as doing in the eye. 2 main ones we have here include tetracaine and proparacaine. These are primarily used for if a patient's having some kind of ocular exam being done or undergoing ocular surgery in order to remove a foreign body, do surgery, anything like that, where you don't want the patient having that sensation in the eyes, okay? We do this all the time in the ER for patients who have to get a fluorescein stain and we're looking for foreign bodies and things like that. So it's pretty handy there. Note that while patients who may have ocular irritation will feel better when they get these, you never, ever, ever want to write prescription for these. Because if they are taking it themselves at home, they're not going to have a blink reflex. They're not going to feel that dryness that occurs that leads you to blink, and thus they can lead to further drying of the eye. It can lead to irritation, corneal abrasion, so it's not good. This is only for in-clinic or in-hospital use. Don't send the patients home with these, okay? Even though it's your nurses might want to hand it to them out the door, don't do it, okay? We also have some drugs that can help to dilate the eye, and this helps us to provide a good field to do fundoscopic exams. We can do this for surgery purposes and things like that. And so there's a couple ways we can do this. We can either block muscarinic receptors, so like I mentioned before, how that can cause mydriasis. So we have things like atropine that can do this. We have cyclopentolate and then tropicamide. Those are the 3 main ones. Biggest issues with these you're going to find is they cause photosensitivity and blurred vision. If you've ever had your eyes dilated, and it seemed like it lasted a couple hours to all day long, it was probably an anticholinergic, antimuscarinic drug you received there, probably cyclopentolate or tropicamide, okay, that causes that dilation to occur. On the flip side, though, you could also do a sympathomimetic, either anticholinergic or sympathomimetic can both lead to that mydriasis to occur there. And this is where we can use something like phenylephrine, which can be really handy. So for instance, a common medication that we use for like neonatal eye exams, it'll be a combination of phenylephrine plus tropicamide. We use that together to get even better dilation of the eyes there. This one you're going to see here, the blurred vision is not going to be as bad because when using a sympathomimetic, the ability to accommodate is still somewhat intact versus with the anticholinergics, those eyes are just dilated wide open and there's nothing you can do about it. So have some photosensitivity with these, but not as severe as you would see with an anticholinergic. And then we have fluorescein, which is typically used to stain the eyes for ocular exams. Again, you use this in combination with the Woods lamp to stain the eye. Typically, it comes like on a little stick that you can just put into the cul-de-sac of the eye and allow it to kind of absorb some and kind of flush it over the conjunctiva. And you can then use the Woods lamp to see if any corneal abrasions have happened there, things like that. For the most part, very well tolerated. There's some burning sensation, but we typically will anesthetize the eye beforehand. We'll use like some of that tetracaine or something before, and that will help to limit some of that burning sensation you'll get there. So So that's it. That's all of the section here. That's it for your first test, right? So we'll do the review next time. I'm going to have that via Zoom session. That we will all be in person there doing that, and then do the review, do the Kahoot, and you'll have a better idea for what kind of questions we're going to be asking on the exam itself. So let me check to see if there's any questions on the old sticky board. I have a few here. Someone said, what is the drug? What's the difference between a drug in solution or suspension? So solution versus suspension. Basically, what that means is how well is that drug going into solution. So if something goes in and it's a nice homogeneous solution, it's a solution, right? Because it means that everything is very well dispersed throughout it and nothing's going to settle out of that. A suspension means that some of the particles in there are heavier than what it's being dissolved in, and so they will then settle down at the bottom. So with a suspension, to resuspend the drug, you have to make sure you shake it up beforehand. So as a general rule, anytime you're dealing with a suspension, make sure to shake it up in order to make sure that the drug is going to be adequately dispersed throughout the vehicle that it's in, right? When I say vehicle, it means that whether it's in simple syrup or if it's in water or whatever the case may be, whatever kind of fluid that it's in, you got to shake it up beforehand, okay? Let's see. What about Bromfed for cough? Yeah, Bromfed, chlorpheniramine for cough. That's more of like a drying type of effect. If you had patients who were having, for instance, like postnasal drip that was causing their cough, that's where using Bromfed or brompheniramine or chlorpheniramine, really any antihistamine could work there. So that's where I'd end up using that for cough specifically. It doesn't do anything necessarily with cough reflux. It just prevents that postnasal drip, okay? Someone said there's a bit of info from the PowerPoints that was skipped over, although you didn't talk about it. Is this stuff we should look into for the exam? Some of the stuff may pop up. I think I hit all the high points though. So I think I hit most of the points. I'm not sure what I skipped over specifically. But it's on there. You know, it's fair game. But honestly, you know, based off of what I'm saying, I'm probably focusing on more of the relevant things that I think I'm maybe more likely to ask questions on. I don't know. I'm just, when I write test questions, I only go to what's kind of most prominent in my mind. And so if I talked a lot about it, chances are it may show up, right? So you'll get a feel for that after the first test. So is it important for us to memorize the list of drugs you're giving us, all the available glucocorticoids for the eyes, or should we focus on specific drugs you go over more? If I put it in one of those lists and I didn't highlight specific ones, they are all fair game for the test. I could pull any one of those and put them as a drug option, right? If I highlight certain ones as being specifically different, like the soft steroids I mentioned, I would know that about them, that those are the soft ones. On the example though, for like the ocular antifungals, I only highlighted like one of those because that was the only one that's commercially available as an ophthalmic product. So that one would be the one I'd focus on from that list there in respects to ophthalmology specifically. See, Isabel was saying, so I was talking about OTC Lumify for red eyes. Let me double check that one. Brand name. I didn't realize that went over the counter. That's interesting. Well, I just learned something new. Very interesting. Yeah, so you could use that. Yeah, that would still have the same ocular. It would have that same rebound hyperemia that you would see for that. So let me put it up here so you guys can see it. There's some pulling up the Lexicon entry for here. So again, I didn't realize it actually went over the counter. So even I learn new stuff all the time. Whoa. Let's see. Bring that down a little bit. Like the dosage forms. So you can see here the different formulations that it'll come in, and then it actually told me up at the top here. You can see here that's an OTC product. That's interesting. I'm surprised they made that OTC. Yeah, but you get the same effects as you would see for the prescription product, for sure. So let's see. And Shelby's asking, is it a myth that marijuana is prescribed for glaucoma? No, that is not a myth. We'll talk more about marijuana later on. But yes, there are some intraocular pressure lowering effects with marijuana. Would we use that as like a first-line therapy? No, but there is still some evidence for that. That's kind of the general thing with marijuana, is that it works for like a lot of things, but the evidence to support its use over other things isn't really there. And so it's hard to say, that you got to use marijuana as like a first line drug. It's not really a first line drug for really anything, but it's an alternative, right? If patients really wanted to try it or something like that, or the providers were amenable to trying it, yeah, no problem. I don't know if there's any issues with it. Let's see, Brittany said my horse tore his cornea. I had to put drops and ointment in his eye every 2 to 4 hours for a couple of weeks. That was, yeah, I can't imagine doing it to a horse. Like horses are kind of scary. Like, they can just kick you and you're dead. So good thing. Hopefully your horse got a better cornea. Got better. Okay, so that's it. If you have any other questions, though, I'll stick around for a minute or two. Otherwise, you're free to go. Have a great weekend, a great 3-day weekend. Catch up, rest, and relax a little bit, and we'll come back and we'll hit it hard next week. Thanks, and I'll see you guys later. No problem. Oh, so I'm gonna ask you. I need to know brand names. I'm gonna include brand names on the test, so it'll be generic and brand on the test there. At a baseline, I would like you to know generics, but I will have both available. All right, you guys have a good one. I will see you all next week.